Dr. Showkathali will just make a next presentation according what is GCC and how GCC can help us in daily routine. Welcome.
Welcome. Thank you. Good afternoon, everyone. Thanks for the organizers to give me the opportunity to talk on radial access chip PCI by the use of glide sheath slender. My previous colleague nicely demonstrated how a difference between the sheath and the catheter sizes, the outer diameter of the catheter size is equivalent to the inner diameter of the sheath. And when you talk about a 7 French sheath, it's essentially... No?
Mute all other mics, please.
Yeah.
Please go ahead.
Yeah, so when we talk about the sheath size, we normally mention the sheath size, 7 French sheath is equivalent to the inner diameter of the sheath, whereas the outer diameter may be around 1.5 French to 2 French, higher than the mentioned size, depending on which company you use. So obviously, when you're using a 7 French, it's around 8.5 French outer diameter. So just briefly to show how the radial access has improved over the years, this is the slide, just a simple British Cardiac Intervention Society slide back in 2012, telling that the access site has moved from 10% of radial to 65% in 2012. I'm sure this is going and going and going. So in the same 2012, we published our data about transradial rotablation in a patient with dextrocardia and acute ST elevation myocardial infarction. So this is this is the time when the chip was not even coined back in 2012. There's a gentleman, 80-year-old guy with a heavily calcified right coronary artery in a dextrocardia, coming with an ST elevation MI, which is thrombolized in the local hospital. But those days we didn't have intravascular lithotripsy, and even though it's a large artery, we went with a 2-millimeter burr and rotablated it, and this is what the results we got. So why do we have to use radial access in chip? Of course, we all know people are moving towards, but when it comes to chip PCI, people are still not keen to move on to radial. But I think there are certain reasons why we should be thinking about radial access. First is, if you use your radial access in a complex cases, you have a good femoral access on your both sides to use your Impella or ECMO or intra-aortic balloon pump. In cases like CTO, where you want to keep your ACT above 300, 350, when you go femorally, there is risk of bleeding is extremely high. And that has been told by my previous colleague as well. So why actually we should not be using radial access? I think we should probably think radial as the first choice in most of these chip PCI. So you remember, when we talk about chip, we talk about either the complex coronary anatomy or the other patient's factors. If you think the complex coronary anatomy is the issue, then you can consider femoral. But I think most of the time we can get away with radial. But if you have other issues like LV dysfunction and so on and so forth, you should actually go for radial straight away, even if it's a chip PCI. So, I mean, I don't want to dwell on this. We have enough data so far starting from Radial back in 2011, and then Rifle ASTS ACS showing that the access site bleeding is significantly reduced, around 47% reduction in access site 30-day bleeding rate with radial compared to femoral in ACS patient. And coming to CTOs, this is a registry from the European registry, the Recharge registry, including around 1,200 patients from different centers, looking at their CTO, totally radial, biradial versus femoral. What they showed is, if your JCTO score is anything between 0, 1, and 2, there is no significant difference in your success rate of your CTO. Even in 3, there is no significant difference, even though numerically it's slightly lower. But if your JCTO score is higher, the femoral access is better. So that's what this shows. This is another data from the North American registry about the same CTO. So they suggest that they either fully transradial or femoral with radial or fully transfemoral. They showed that the success rate of the outcome is the same, whereas the bleeding rate is extremely high. We use the femoral access, whereas in the radial access is extremely low. So I think we have enough data to show that radial is kind of equivalent to femoral access in most of the patients we deal with on a day-to-day practice. See, as my previous colleague just briefly mentioned about the glide sheath slender, essentially the advantage of this sheath is actually the 7 French sheath has got an outer diameter which is equivalent to a 6 French normal sheath. That's the basic point you need to understand. When you talk about 7 French glide sheath slender, the outer diameter of the 7 French glide sheath slender is equivalent to a 6 French normal sheath. So if you're doing your PCI with a 6 French normal sheath, you can always use a 7 French slender sheath to do that. So by doing that, what is happening is it improving your inner diameter, opening nicely for your 7 French guiding catheter to go very smoothly inside your coronary arteries. As we know that most of the complex PCI, we prefer 7 French, particularly in radial, because it gives us more support to deliver devices in positions. So, but there are certain things with this slide that we need to be aware of about, because it's so slender, the thickness of the cover diameter is slow. It also has a slightly higher chance of kinking, but you do have to have some tricks to avoid that happening. So let me show some of my cases, which is what the main theme of this, to how my glide sheath slender has helped me. So this is one of these early cases of transradial rotablation with OCT guidance in a 7 French slender sheath and a 7 French guiding catheter. You can see the calcium in the LAD. The OCT nicely showed that calcification, and I straight away went with a 1.5 millimeter burr, around 175 rotations per minute. You can see the burr going in, and then deploy the stent. So it's kind of a reasonably simple form of chip PCI, if you want to call it as. So where the rotablation, the rotor burr went very smoothly from that. So this is another gentleman, 72-year-old guy who had a single kind of coronary artery, but actually the left system is coming from the right sinus, but the roof of the coronary arteries are the same. It's rising from the same roof. There is a tight lesion at this circumflex after the tortuosity, and on the pigtail catheter done in the hospital, there's not any left-sided system coming at all. So one of the things, advantage of this is because it's the right coronary, this is all is nearly a single coronary artery. You don't want to damage the ostium of the coronary artery. So this is the Amplatz guiding catheter I used. I put a wire to support on the right coronary artery and then went the other wire to the circumflex artery. And just to avoid this, I cut a guidezilla in and get the guidezilla all the way in deeply, and then deploy the stent, thereby avoiding any damage to the ostium of the right coronary artery, which is because the right coronary artery is a major artery for the supply of the coronary artery. So another case, this is a IVUS guided DK crush left main PCI through the right radial axis. So you can see it's a Medina 111 classification, the obtuse marginal and the circumflex involved. The LAD has got a very tight lesion up to the mid segment. You can see this in this particular slide, you can see the S-shaped part of the catheter from the right radial artery, 7 French. So what I'm trying to say, even though it's an S-shape, the IVUS catheter went very smoothly. There is no issues. And I deployed the first circumflex stent and pulled back and ballooned it. And then we can see when you have a 7 French, it's always better to have a 7 French when you go for kissing, because the balloons move very smoothly. And this is what I had. And they put the LAD stent. And the double second kissing, and this is the final result of that. So you can imagine, even in very complex left main bifurcation PCI, you can use a 7 French guiding catheter very nicely and get your results, better results as such. And this is a very complex rotablation where when I try to do the right radially, the rotor burr, whenever I want to bring my rotor burr in, it just pushing the guiding back. So one of the tricks you can do is you can pass another wire into the circumflex and try to get the rotor burr on the rotor wire to give us more support. When I tried that, it still didn't help. Then I have to use a guidezilla to just feed it on the rotor wire, kept the guidezilla in position, and then got the rotor burr through the guidezilla. And this is the rotablation done through the guidezilla, right radial axis in a 7 French sheath. So this is a 1.25 millimeter burr. It's a heavily calcified vessel at this segment, and I nearly got caught with entrapment, but then I have to pull it just gently with a higher rotating speed as such. So this is on the highly complex rotablation. They still managed to get through the right radial axis, and this is the last result of that. And in coming to CTO PCI, this is a biradial retrograde CTO, which I did in the lady CTO. Right coronary artery was nicely supplying the distal vessels. And so I used cyan through the antegrade approach, and then this went through the retrograde with the Corsair and managed to go with the SO3 wire and entered into the antegrade lumen. This is both biradial axis, both sides. The patient was around 45-year-old guy, very cooperative, and I managed to get through that. You can see this nice 2 catheters coming, and then I got the RG3 wire and just ballooned on the RG3 wire, and then went antegradally and finished off the case. So I think these are the important cases to show, even with the access of right radial with the slender sheaths, we can manage. This is the last case of my transradial primary, which is a very recent one. A 73-year-old gentleman, anterior wall ST elevation MI, LAD occluded, as you can see here, heavily calcified vessel. There's no flow, and when the wire passed through, and I could manage to balloon the proximal segment, but what I was there happening is the distally I could not get any balloon. There's a very tight lesion there, and I could not get anything beyond that segment despite my effort. So I have to use a rotablation. So the occlusion of the proximal segment, but this segment was not giving away with any balloon, even the 1 millimeter balloon. I didn't have a 0.85 on the stock at that time. Yeah, so I think that's the last case, and then I put a stent there. Just to quickly last a couple of slides to show that, yeah. So one of the things when we talk about slender sheaths is when you put your guide lead slender, the first thing you'll notice is the slender sheath will look above and in an around 60-degree angle above it. So when you're trying to push something, be careful because there will be a high chance of kinking, but it's because so flexible at this segment. So one tip I would say is normally put a Tegaderm band just to fix the sheath in position, because normally we don't normally put sheaths on the transradial. I don't put for my normal sheaths, but in this sled sheath slender, definitely you have to put a thing because it's so slippery and you can come out when you exchange the catheters as well. So, and also I would say that you have to use a radial arm board, because when you're going by radial, or if you want to switch over to a IABP on the left femoral, it's better to have a radial arm board than your long things. So I think in conclusion, radial chip is feasible in many patients, but not for all patients. You all agree with that. There are certain cases you have to go femorally. Know your kit and keep it ready in the cath lab. Plan your strategy ahead, including the support devices and bailing techniques, and feel free to switch over. The most important thing that you don't want to keep going on and on. You have to feel free to switch over to femoral if needed. Thank you for listening.
Thank you, Shaukat, for telling that last point also. Sometimes youngsters keep on chasing, and it's as if it is a crime to go to the femoral. I don't think it is the right approach. What is required for the patient and keeping the patient safety in point of view, we should do our best. I think that point is highlighted. Regarding the advantages and disadvantages of each of that catheter versus the sheath usage, we'll discuss it then.